Good afternoon. I'm here again. And many thanks to the organizer for this opportunity to be the first speaker in the first plenary. I'm very honored for this. And let me say that I try to put in I have an enormous amount of slides I will have to run to show you in a subliminal way these slides. But I wanted to tell you an episode of my life 10 years after my graduation in the medical school, and being a practitioner working with drug addicts, with drug users, with heroin addicts, 800, 900 drug addicts per year for many years. I went to see one of my patients in the orthopedic department. You know that our patients have frequently car accident. He has broken a leg. I have to go there for detoxification. And I went to see this patient. I met an old colleague who said to me, "Where are you working now? It is already 8 years I don't see you. Where are you working?" I said, "I still work with drug users, with drug addicts in the drug addiction treatment service." Oh, he said, "I remember you. You were a brilliant student. Why you have finished your career in that situation? Why you are there?" So can you imagine? It is working with drug users, working with drug addicts. I think that this is belonging not only to Italy, to my country, but to all the countries, is diminishing the dignity of the professional. Why is diminishing the dignity of the professional? Because we don't know and we don't do publicity to the things I will try to show you in these slides this afternoon. Because we ignore the real nature of the disease that we are called to treat. And as I say in this slide, it is a non-recognized disease, discriminated, with a sort of setting aside from the public health system the good disorder, psychiatric disorder, schizophrenia, depression, anxiety are there in WHO interest. If you are addicted to legal drugs such as tobacco and alcohol, you are considered, in a certain sense, you deserve the attention of the public health system. If you are addicted to illicit drugs, to the controlled drugs, you don't deserve anything. You need only to be put out of the society and marginalized. What we see at the beginning of the history of our patient is a very important genetic component. You can see this study is a meta-analysis of twin studies where they compare monozygotic twins with exactly the same genotype with the non-monozygotic twins and twins that have shared the environment or not shared the environment. To make the long story short, they find 48%, for example, in the males, of component of genetics in the vulnerability for initiation to cannabis. I'm not speaking about cannabis use disorder. I'm speaking about initiation to cannabis, experimenting with cannabis, and 40% in the female. You see that the inherited component, a component related to genetics in this disorder is always more when you look to the real disorder, 51% and 59% for the drug use disorder. But also, I want to attract your attention, to ask your attention, particularly on the issue of initiation. When you say, this guy has decided to say yes, to try to experiment with cannabis. This is not true. There is a large component of genetics, for example, that is conditioning him or her to be predisposed to initiation. And this study is telling us, Kendler is telling us that the predisposition is not specific substance by substance, but the predisposition is related to the predisposition to drugs, to experimenting with drugs in general. But all the people are very confused about what is the real role of genetics, what the genes are doing to help people to remain trapped in drugs. And it's very easy to understand if we look what the genes are able to do. The genes are able to modify the temperament, to influence the temperament. You can be a sensation seeker or a harm avoidant guy because of your genetics, what you inherited from your father, your mother, and your grandfather and grandmother. And you can be motivated of having a reward system tone very active or be demotivated, or you can have an inhibitory control mechanism working well in the prefrontal cortex or not. You can have a psychobiological response to emotion very strong or very, very controlled, and so on. So genes are influencing very much the temperament, the tone, the personality traits of the individual. And this can influence directly his choice, his predisposition to use drugs, to experiment with drugs, but there is also a terrible thing. This predisposition, this genetic temperament is going to influence our relationship with the parents. You see, the parent-child attachment is influenced by genes. And you have here one of my studies showing, for example, that if you are carrying a certain genotype at risk influencing the serotonin system, you are more aggressive and more novelty-seeking. But what happens to a child more aggressive and more novelty-seeking in the relationship with his or her parents? You see, this study is saying that the parent sensitivity and the infant temperament are meeting each other to create the condition of attachment. You can have an insecure, disorganized attachment because of this not fitting each other, or you can have a secure and organized attachment. Is it a fault? Is the fault of the parents? No, there is no fault. No one is guilty in this game. It is a situation as it happening normally, creating the condition for the beginning of a disease. There are candidate genes, for example, for cannabis, or genes in general affecting the predisposition to drugs. I don't want to spend time. But come immediately to something that is putting together the genes and the environment. You see that this serotonin transporter gene influencing the variant of the serotonin transporter gene, the variant short, influencing this associated with drug initiation. If you go and check in this big sample of 1,000 adolescents, 1,100 adolescents in my country, you go and check for the real, what is mediating the effect of genes on the predisposition to use drugs, you find that is mother and father neglect, parental neglect is the real factor mediating the capacity of genes to induce the predisposition for drug initiation and drug use disorder. In reality, what is very important is the environmental factor, is the family having more power than the genes themselves. The same for this other gene, other study, other group. This is the 7-repeat allele dopamine receptor gene D4. Also, this associated with cannabis heavy use, but when associated with cannabis heavy use, only in the patient, in the subjects, were also anxious avoidant parental-child attachment. If you don't have an anxious avoidant parental-child attachment, you don't have the same, a very low significance of the association between genes and cannabis use. Again, this supportive parental style, engaged and supportive parental style that is able to reduce, to attenuate greatly the risk related to genetics. I want that you give me your attention, particularly for this unbelievable study. For example, you are carrying this genotype that we didn't understand is the genotype affecting the serotonin system. If you find that this genotype is together with the secure attachment, what is the product, the behavioral product in your adolescence? You have an agreeable autonomy. What does it mean, agreeable autonomy? It means that you are available to dialogue with your parents, with the teacher, with the adults. When you have this genotype together with an insecure attachment, you come out with hostile autonomy. The child, the kid, or the girl is putting himself or herself in a separated world that does not want to have any dialogue anymore with the adults. And you understand this is the real risky condition for substance use disorders. But you understand that autonomy is a good thing. Now, in reality, the genotype at risk is not a genotype at risk. It is inducing a good thing that is autonomy, novelty-seeking, explorative behavior. These are all good characteristics in adolescence. But if they are matched with an insecure attachment, this is becoming a risky condition and is probably preparing the future of the trajectory of this guy or this girl in a bad situation. Look, that parenting is always more important than genetics. Also in this case, emotionally unstable, lower emotional stability children are responding better to parental control. If you invest in parental control, these children are more responsive than the so-called normal children. And what is the mediator? One of the main mediators of this relationship between gene and the environment in building the pathogenesis, the etiology of our disease, is really the hypothalamus-pituitary-adrenal axis, the axis of the hormones responding to stress, from CRF in the hypothalamus, ACTH in the pituitary, and cortisol in the adrenals. And this is becoming a sort of a vulnerability system. You see, for example, children who are available to
smoke very early, to have early onset of smoking tobacco with high level of cortisol, a sort of internal stress that is not prepared to respond to stress, but is responding to this permanent internal stress related to this kind of childhood adverse experiences. We published very recently, also my group, about addiction severity related to childhood neglect, to altered response to emotion, and hypothalamus pituitary adrenal axis dysfunction. But I want to introduce you to a thing that is really new. And we know this as bad news and good news at the same time. Look to this experiment. This experiment is telling us that maternal care or maternal neglect can change the reading, the transcription of our DNA. So imagine that our genes are the genes that we receive from the parents, from the mother and from the father. But environmental factors, in this case, mother neglect or father neglect, mother neglect or maternal care, can influence the way the DNA of the genes is translated to RNA. And so as a cascade is going to influence hormones, enzymes, receptors in the brain that are not what you inherited. It's not the code of the things that you inherited from your parents. Is this code modified, changed by the neglect or the care that you received? Here you see maternal care able to silence a gene, or maternal neglect able to activate a portion of a gene. This is another impressive study showing that childhood adversity are able to induce methylation. Methylation is exactly this operation to change the loops, the dimension of the loops of the genes, going to modify the transcription of the genes in the DNA of the genes in RNA, and going to influence very crucial receptors, such as the opioid receptors in the brain, gamma-aminobutyric receptor, and dopamine receptors. But I want to speak also to low-income countries and poor people in low-income countries. Look to what has been found because of poverty and stress during childhood. This is not simply maternal or paternal neglect. Is poverty and stress during childhood able to modify our brain? Where? Modifying our brain in the amygdala, that is the store of emotions, and making amygdala hyperactive, and making our control system in the prefrontal cortex hypoactive, with the emotion regulation that is becoming less operative. Imagine poverty and extreme poverty and this kind of social exclusion and stress during childhood. Imagine in a post-conflict country, in a conflict country, exposure to violence, both domestic violence and violence outside. What happens in the brain of people, preparing them to be ready for becoming drug users, experimenting with drugs, and then transition to drug use. I listed here, I don't have the time to go through. My slides will be available for everyone who wants to take these slides, but look to the long chain of disadvantages in the so-called Western world, starting from the relationship with the parents, bonding to family, engagement in school, and so childhood neglect and abuse and so on. But look what happens if we transfer ourselves to low-income countries, with people with really suffering extreme poverty, suffering violence, exposure, exploitation, eradication from their territory, and also sometimes having to use drugs to cope with anger and overload of the work overload. So we are speaking about something that, as I said this morning, cannot be called so much recreational, and is the basis, the pathogenesis for a disease. I go fast. These were some recommendations, but I have already said. But look to the mechanism itself. We know a lot today about what is the mechanism itself to make drugs able to put people in a trap. You see that from the ventrotegmental area to the nucleus accumbens to the prefrontal orbitofrontal cortex, this system is completely hijacked by drugs, and we have established uncontrollable compulsive behavior. I want drugs, I want drugs, I want drugs, then some regret, that again a cycle, I want drugs. And we say that there is a sort of usurpation of the emotional memory. All the rewarding system is focusing only on drugs. And you remember, if you also offer any monetary reward, these people are not reacting, they react only on drugs when the compulsive system is established, compulsive cycle is established. Another allegation against my patient, your patients are procuring themselves pleasure all the day and night, injecting and obtaining pleasure. This is completely wrong. Our patients have pleasure in the beginning, when they are not still addicted. When the brain is becoming an addicted brain, you don't have any more pleasure. You have only the efforts to reach a sort of normal mood, and sometimes this is not easy to obtain. This, for the courtesy of Professor Koob, I can show you this cycle of addiction. When you on an hedonic scale, a scale of pleasure, you see that you start to have less and less dopamine, less and less good rewarding hormones, more and more cortical releasing factor, and the pleasure is no more there. You are only struggling, rushing to try to obtain a certain level of normal mood. This is the slide showing that if you give to a cocaine addict, monetary reward is not reacting. As if I come in the room and distribute $1,000 to each of you, you are reacting, but our patients are not reacting anymore. The entire system is hijacked by drugs. And sorry friends, to disseminate too bad news about our disease, but what is the mechanism? Again, we said before that adverse childhood experiences are affecting the brain and are affecting the transcription of our DNA, our genes. But what is the mechanism with which drugs are affecting our brain and establishing the stable compulsive behavior that Professor Koob described so well? The mechanism is, again, unfortunately, an epigenetic mechanism. You see, in my time, when I studied in the medical school, we were thinking that it was only a functional issue. The synaptic function, the receptor function changed by drugs. But that is functional, is very easy to solve. But if the things are written in the transcription of the genes of the brain, you understand that the things is becoming more and more concerning and more serious. And de facto, our patient can be called submitted to epigenetic effects twice, because of their clinical history when they are young, because of the exposure to drugs when they are adult. I don't want to show you the acetylation going to modify the epigenetic changes and increasing the sensitivity to reward of this threat. But I have also some good news, because after so many bad things, I have to try to go toward some good news. The recent studies are really challenging the idea that epigenetic changes are irreversible. They are not. There is a continuous plasticity. And this means that, for example, a treatment opportunity or prevention opportunity can change the reading of DNA of the genes. Clearly, you don't do this with one hour a week of psychotherapy. You need a very intensive care and intensive caregiving to modify, to revert the epigenetic changes. And don't forget, please, I ask this, I have here my friend Nico Clark from WHO, from the World Health Organization, working in the mental health department. Don't forget, among our patients, very high rate of psychiatric comorbidity that is also not so recreational. And comorbidity could be other substance use disorder, antisocial personality disorder, mood disorder, and so on. Here I have put in red only one word. Most of the time, psychiatric comorbidity is predate to the development of substance use disorder. Mental health disorder before, sometimes not diagnosed, early onset bipolar disorder, early onset personality disorder, that are going to use drugs, and they are completely not considered, not diagnosed first by the family, by the parents, then by the doctors and by the psychiatrists. I go very fast. But pharmacogenetic effects, let me spend 1 minute on this. Every one of us is responding to drugs very differently because of our genetics. And when you experiment with cannabis the first time, if you have this kind of single nucleotide polymorphism affecting your genes, in particular for the enzyme, the COMT, that is catechol-orthomethyltransferase, the enzyme metabolizing adrenaline and noradrenaline, you have an immediate, a very, very sure reaction toward psychotic symptoms smoking cannabis. If you don't have this genotype, you can smoke cannabis, you don't have a psychotic reaction. So imagine when they say we have to understand if drugs are soft or hard, if cannabis is soft or hard. Who can say in the reaction of a single individual if it is soft or hard? For example, in the case you have carrying this kind of single nucleotide polymorphism, your response to cannabis is completely different from your peer, from your classmates who is not carrying this genotype. And the same, imagine, this genotype you see in light gray, you can see in the slide in the people having more risk of psychotic reaction because of this valine instead of methionine genotype, but on the right side of the screen, unfortunately, you see that also sexual trauma during your childhood history is making exactly the same effect. So it's making you more sensitive to cannabis and able to create a terrible reaction, a psychotic reaction, because of your clinical history. So both environment and pharmacogenetic are concurring, are contributing to bad reaction to drugs. Are drugs, someone want to say, we have to put drugs in an unrestricted market, in an uncontrolled market. But friends, look to the reality. I'm not speaking about 10 years of heroin or 7 years of cocaine. I'm speaking about few weeks of ecstasy. Few weeks of ecstasy in 6 months can provoke, for example, cut of the bottom of the synaptic system. The synaptic system related to serotonin, inducing a sort of depression, anxiety in human laboratory. And methylphenidate, someone say it is good. Methylphenidate is very good for medical purposes, to treat ADHD, to treat attention deficit disorder hyperactivity, to treat narcolepsy, to treat extreme obesity when the people are not in control of their appetite. But look, if someone is asking for methylphenidate to me as a doctor, say, I want to do an after-hour party in Lugano, and I have to dance until 4 o'clock in the night, is methylphenidate the appropriate medication? Can I prescribe this for so-called medical purpose? Is this a medical purpose? For sure, I have the risk to induce arrhythmias, agitation, anxiety, weight loss, and hypertension in this individual, obtaining medical problem, not treating or curing medical problems. Again, mephedrone, I'm very happy that mephedrone was one of the first of the 10 substances, new psychoactive substances, that the Commission on Narcotic Drugs has put under control in March 2015, few months ago. Mephedrone was suggested by the United Kingdom as a dangerous drug. With the bless of WHO, the World Health Organization, we have put mephedrone under control. There was people dying for cardiovascular disorder. Marijuana, cannabis, is considered by someone soft. But go to look to the reality. The car accident with the contribution of marijuana, and what is the adverse effect on the adolescent psychosocial development and mental health disorder produced by marijuana. This is a very important slide. It's a slide of thrombosis of the basilar artery in the brain provoking a stroke. This guy died for a stroke. And I ask you, is this the result of 7 years of cocaine, 7 months of cocaine, 7 days of cocaine? This was the first time this individual was trying cocaine. Cocaine is a terrible vasoconstrictor. It provoked a vasoconstriction in the brain with a thrombosis and a stroke, and he died. So these drugs are objectively dangerous, also for an occasional use. These are the people dying in the United States for prescription drugs, and so on. I go to the second part and final part of my presentation, looking to, is substance abuse preventable and treatable? Yes, it is. But we have to look to this reality, not to the reality of the people having all the benefits in their society. The very poor people who are in condition of marginalization, social exclusion, no perspective, they have no perspective to go to the college, they have no perspective to have fun with their friends. Sometimes they are really living in a marginalized situation. And what about the prevention among these children sold by the human trafficking criminals? In this case, it's not enough to have a simple program for prevention, as we imagine always to do in school or with the family. We have published in 2013 the International Standard of Prevention. UNODC, my organization, was leading a group of all these organizations collaborating. They are present also today in this meeting. But we have done this important reference to see what can be done to improve the real quality of prevention. But before speaking about programs for prevention themselves, we have to speak about inequality, about fighting inequality, about children's social protection in general, about early screening of children and support to their family from the educational point of view and social point of view. Then, when we look to prevention, prevention is absolutely working. If it is done following a science-based methodology, it is working in a very, very clear way. I show you here 5,000 students that are responding between 13 and 15 years old, submitted to life skills education program. They are going to reduce 4 times their initiation to cannabis, inhalants, and alcohol. And look to what happens if you combine, if you put together life skills education and the family strengthening program, no, going to improve the capacity of the parents to be good parents, what happens? You have 10 times less the use of methamphetamine in the 12th grade. And look, this is another, for me, I would like to print a T-shirt with this graph, because you can see that the children carrying this D4 receptor genotype, so children that should be more impulsive, more problematic, when you give them more good parental monitoring, they are responding well, they are responding better than the children without the genotype at risk. So it is encouraging the parents who have a child with difficult temperament not to despair, not to be discouraged, but to say to these parents, please invest in monitoring, in attention on your child. You will obtain better results than other parents with better children. Again, good game behavior in prevention, showing better results in children rated aggressive, more aggressive when they are in the first elementary school. Our 4 elements for prevention: parental monitoring, undivided time for children, warm supportive style, clear rules in family life. Not psychologism, very simple things that we can teach all around the world. Is treatment working? But not in this condition, is my response. This is not treatment working well. But, and also a study of CASA, Center of Addiction and Substance Abuse in Columbia University, no, that was before managed by Joe Califano, now has done a study on huge amount, a large group of treatment centers in the United States. Imagine that is the cradle of science for drug abuse treatment. And do you know what they found? They found that most of the professionals working, also health professionals such as doctors, nurses, and the counselors, most of the professionals working in the treatment center have not a clear idea of the nature of the disease. Can you imagine? This means that we are in the middle age. We need to invest resources in training, licensing, and preparing this personnel, and qualifying this personnel. We have this huge program with great program with the WHO in more than 25 countries, disseminating good practice in treatment. We have a list of things that we know are working. We have not to spend time in discussing too much. If you go to implement brief intervention, cognitive behavioral therapy, self-help group, they are working and they are giving huge results. Look to what is the result of ATOS study, Australian Treatment Outcome Study. They have followed the patient treated with 3 types of treatment: methadone, detoxification, and residential treatment. No? Most of the time we spend time to fight the therapeutic community against methadone, the methadone against the detoxification. If you put all these forms of treatment together in a pot, you mix, and you follow the patient for 11 years, this is the ATO studies, follow the patient for 11 years, you see the number of abstinence people in violet is impressive. Abstinent people who are not using any more drugs after 11 years because they were on treatment. So imagine the saving of money for the state in terms of cost effectiveness. Look, the level of mental health disorder going down in this ATO study, going down after 11 years very, very significantly. Look, the level of crime going down very significantly in the people in treatment. This is another study on the weeks drug-free when you are in naltrexone, with naltrexone long-term release, slow release. Also naltrexone, a tool that is not being utilized but is very effective. And what happens when you are in treatment with buprenorphine and methadone to your immune system? People are not aware. When you are in treatment with buprenorphine treatment, after a few months, your immune system is going back to normality. You see in the low level of response to phytomagglutinine or to stimulants for the lymphocytes, in the low level you find heroin. If you put people in treatment with methadone and buprenorphine, they are long-acting, they are respecting the lymphocytes, the white cell, your immune system is going back to normality. You are not different from the normal people. And again, contingency management, 20% less of use of cocaine among people using methadone. 20% less means less cardiovascular disorder, less stroke, less car accident, a lot of better life, no money spent for the criminal organization. And so, perspective in the treatment of stimulants. We need half of the world, more than half of the world now is using stimulants and no more opioid or depressant of the central nervous system. They use amphetamine, methamphetamine, and cocaine. I know that, for example, here in Thailand, the main use is exactly related to amphetamine and methamphetamine. We don't have until now responses. Well, we have some promising medication. We have to start to study subtypes of stimulant user responding to this medication, not giving up to this kind of not successful results. This, for example, is a study of my friend Adam Bisaghi in Columbia University showing that that topiramate and Adderall, a cocktail of amphetamine, were able to control the use of cocaine. Let me show you, I'm going to finish, I understand I have taken too much time, but I wanted to share with you this perspective. And I have here a very impressive study. This author is going to modify what? To try to revert epigenetic changes. And the objective of reverting some epigenetic changes with drugs is what? Is going to have an extinction of drug-seeking behavior or an extinction of fear in post-traumatic stress disorder. We are speaking about fantascientific world. It's probably not available today, will not be available next week or next month, but is the future, where we can also imagine to cure, not only to treat, drug dependence, because we go to modify what was modified before by the vulnerability condition and by drugs themselves. Finally, let me remind, no compulsory treatment. Let me spend one word on this. People have to be the right to enter in treatment voluntarily because they like and they are receiving appealing message from the treatment center, offering something good, attracting them to treatment, and establishing with them a negotiation, a therapeutic alliance, and all the necessary flexibility to maintain them in treatment without the need of labor camps. Also from the point of view of the preventing the health and social consequences. Look, this is needle and program exchange plus methadone obtaining a reduction of the incidence of HIV and hepatitis of 54% respectively and 60%. So very impressive. It also, these things have already been found effective, should be simply implemented as they are. And finally, let me say that going on mission around the world in these 8 years and visiting most of your countries and looking to the reality, I developed a very obsessive concern. Let me share with you finally this obsessive concern. The obsessive concern is about the empty services. I see sometimes 12, 15, 20 staff in the personnel, and they say, Wednesday morning, working time, where are the patients? And I don't see the patient. The patients are, two have to come tomorrow. Which way two? How many patients you have in charge this year? 120, 350 in the waiting list, but they don't come. So at the end of the story, this is the only discipline where the doctors are happy not to see the patients. If you take a cardiologist is crazy for patient. Public patient in the morning to become more visible, more powerful, having more beds in the hospital, and private patient in the afternoon to make more money. But in our discipline, say, no, I am a poor, depressed doctor of drug user. I don't want to see them. I want my salary, but please don't make me see these troublemaker patients that are the drug users. We have to create, with this new development that also we are promoting here in this conference, a new generation of doctors, nurses, and health professionals very, very much passionate and enthusiastic of seeing the patient because they know the complexity and the importance of this disease. They know that it is more complex and more interesting, more fascinating than many other psychiatric disorders, and we have to create a generation of people who want to attract the patient in the service, not only receiving a salary at the end of the month. And to do this, we really have this kind of capacity to engage them, to engage the patient, to attract them with some social advantage, such as food or housing or social protection, to have a one-stop shop offering them all the services managed by the same team, to offer medication. It's very difficult to catch people without offering them medication, helping them for both withdrawal and craving, and to engage their family. Said this, I wish that we start today with this first plenary with a sort of world mobilization for prevention and treatment of substance use disorder, with the public health and human rights approach, obtaining our motto of the program with WHO, nothing less than what is provided for any other chronic disease. Thank you for your attention, and sorry for the time.